In MR, long scan times mean imaging is compromised by the body's movement. What if deep learning could help MR finally keep up with the human anatomy? This is our vision for light-speed imaging.
Good morning. Welcome to the GE Product Theater. The topic is setting the pace for innovation in cardiac MR with deep learning. And there's nothing like a man in a bodysuit to wake you up in the morning, so we thought that would be a good intro. My name is Anja Brau, and I'm General Manager for MR Clinical Solutions and Research Collaborations for GE Healthcare. And I will kick things off and introduce you to the concept that DL is finally allowing us to keep pace with the human anatomy in cardiac MR. And then I'll turn it over to my esteemed collaborator, Dr. Melany Atkins from Fairfax MRI Center and Inova Health System, who will talk about the very latest results with our brand new DL package called Sonic DL. And this is really world's first results, clinical results in real patients, and we're really excited to share them with you. I hope you'll really like them. So just to set the stage, as you all are very well aware, cardiac MRI is a fantastically rich modality, enabling us to scan anatomy, structure, function, flow, etc. But it comes with many challenges. And considering this from the point of view of the technologist, trying to troubleshoot artifacts in certain patients, from the radiologist or cardiologist side, how can they get fast, consistent results in every patient, not just the healthy ones? And from the patient standpoint, why are there so many darn breath holds, and why is this taking so long? And in particular, difficult to get high-quality images in the sickest patients who have arrhythmia or can't hold their breath. So despite growing clinical evidence, these exams are still slow, complex, and of variable image quality, which is something we really wanted to address from the GE side. And the reason it is slow and complex stems from the fact that the MR acquisition speed is fundamentally mismatched to the speed of the heart. And even if you scan as fast as you can with conventional techniques, for example, in a cine acquisition, without any type of modern techniques, you can't keep up with the speed of the heart. The spatial and temporal resolution is insufficient to keep up with the speed of the heart. So what we have done conventionally for decades, really, is to segment the acquisition over multiple heartbeats in a segmented approach. Collect portions of data over multiple heartbeats, and then stitch them together, pretend they were all acquired in the same heartbeat. And this is what I like to call the fake it until you make it approach. We know this is not the way you would do it if we could scan as fast as we could, but this was what we could do with existing techniques. And so what the conventional approaches today that everybody uses is we can reconstruct one conventional heartbeat, as you see in the cine movie on the right, but it was actually acquired over something like 10 heartbeats. And the patient has to hold their breath over those 10 heartbeats to keep the same position and prevent motion artifacts from happening. So we know that that's difficult for the patient to do once. How about 12 times for the whole short axis stack? And then your long axis views, et cetera, you're very well aware of this, and it's just exhausting and difficult for the patients, and especially the ones who have shortness of breath. And so what we'd like to get to is where we're scanning fast enough so you can do true real-time imaging, that is imaging within one heartbeat, whether it's for cine or delayed enhancement, what have you, and do this with high quality without trade-offs. So this whole MR exam workflow from setup and planning, there you see the picture with our air coils, which are nice and flexible, and you can get your hands on one in the booth, including cine, late GAD, and report, ideally all free breathing with everything acquired in one heartbeat in true real time, ideally in 15 minutes. That's our goal, and we think we have the tools to get there now. And how we get there is with deep learning. And it really, we think, enables this paradigm shift in CMR where we've always wanted to be but didn't have the tools yet. At GE Healthcare, we're really proud that we topped the list of all AI-enabled device authorizations more than any other medical technology company. And that's across modalities, but in particular in MR, we've had a lot of AI introductions over the last few years. And this really began with something called Air Recon DL. This was launched about 4 or 5 years ago and is a deep learning-based reconstruction embedded in the reconstruction on the scanner, which does two things. It removes image noise, which improves the SNR, and it targets Gibbs ringing, truncation artifact, and removes ringing in an intelligent way. So this improves the SNR and clarity of the images, which can then in turn be traded, if you like, for shorter scan times. It's compatible across all anatomies, all coils, and available on all of our scanners. And we've applied it to all of our exams, and over 99% of exams have been able to benefit. It has had a long runway to date, as I mentioned, over 2,000 global installations, and over 10 million patients have been scanned with Air Recon DL. It was initially released with compatibility for 2D imaging. Recently, we announced the extension to propeller imaging, which is for motion robust imaging, for example, here in the shoulder, using a non-Cartesian approach. We then also extended it to 3D imaging for example, widely used in the body and brain, also in the heart. And importantly, quantitative imaging as well, so techniques like diffusion and mapping. So really, wherever we've applied it, we've seen a nice improvement in image quality and scan time. But for this audience, we care about the heart. So is it compatible with the heart? The answer is yes. We started with the techniques on the top, like black blood, perfusion, late GAD, both segmented and single shot, and then added mapping T1 and T2 and the 3D heart and 3D delayed enhancement techniques. So these are all now compatible with Air Recon DL in our product, which is we're really proud of. But what is it? I want to explain a little bit about what Air Recon DL allows you to do from a sort of physics perspective. So if you imagine this graph represents the conventional protocol space that you have to work in, and if you consider the variables that we have to play with, voxel volume and scan time, and we know that there's this trade-off. If you want to reduce voxel volume, you have to move up that red curve and scan for a longer time. If you want to reduce the scan time, you give up SNR, so you have to make your voxels bigger. So we're constantly sort of trading off along that red curve within a very narrow red patch of acceptable SNR space before we exceed the thresholds of clinically acceptable scan time or resolution. So this is how things were before. When you add Air Recon DL on top, what it effectively does is shift that red curve down. So our clinically acceptable SNR space that we have to operate in expands quite a bit. And so now if you want to push parameters that you would otherwise not push because you didn't have sufficient SNR, you can do that because the Air Recon DL buys back SNR. Or if you want to, yes, reduce your resolution or scan faster, for example, increase your bandwidth, increase your parallel imaging factor, all this now becomes possible in this blue parameter space. And what we found is that most protocols end up benefiting from a combination of reducing the voxel volume and reducing scan time. So you get the best combination of both, which is typically unheard of in MRI. So how does this benefit cardiac imaging? So in a case like this, on the left was a conventional LGE where actually one of the coil elements was out, unbeknownst to the operator, but that same data reconstructed with Air Recon DL on the right recovers a very nice image. So this is a way of showing you that where you have SNR that's kind of on the edge, this really recovers image quality to be clinically acceptable again. You don't have to repeat the scan on the left. Or what about in single shot imaging, which inherently conventionally was lower SNR because you just don't have a lot of data over which you're acquiring. Or if you apply a gray blood technique, that is definitely reducing the SNR, but adding a Recon DL on top of that gray blood single shot boosts the SNR, and you can see subendocardial enhancement very nicely. So again, just ensures robust clinical performance. Or with patients with ICDs, this is all of our LGE, or we call them MDE sequences, are inherently wideband, but you often make trade-offs in an implant case, increasing the bandwidth or reducing the flip angle, for example, which brings down the SNR. But that same data reconstructed with Air Recon DL boosts the SNR to be something that's much higher quality. We did a number of studies evaluating this clinically. This was a paper with Dr. Alexander Hirsch from Erasmus, who looked at measuring the image sharpness and found that air recon DL significantly increased the image sharpness and the image quality based on visual assessment, and also looked at the quantification of lesions and found that that was also preserved, which was clearly important. This was a study with Dr. Amit Patel on perfusion, showing that air recon DL applied to perfusion significantly improved SNR, artifact burden, and diagnostic confidence. But importantly, this study, I feel like, shows the benefit of techniques like DL moving us closer to that single-shot paradigm. So this was a study with Dr. Gianluca Pontone from Monzino, Italy, comparing segmented 2D MDE, or LGE, versus conventional single-shot versus single-shot with air recon DL. So you see two patients there in the different rows, and their results showed that single shot was not only 3 times shorter, which we always knew single shot was shorter, but it was also with superior image quality compared to segmented MDE without air recon DL. So this gives us now a way to look at single shot with air recon DL as potentially the default, because the image quality is better than the segmented in many patients and was done in 1/3 of the time. So that was air recon DL, which I said was launched a few years ago. But what I want to introduce you to today is the next chapter in our deep learning revolution, if you will. And it was really to continue to think about the problem of, can we use DL to image even faster, in particular when it applies to techniques like cine, where you're trying to capture the function of the heart. So I have a short movie to play to introduce this concept. This is called Sonic DL, and it was 510K cleared by the FDA shortly before ISMRM. And we like to call this technique imaging at the speed of life. And it is a deep learning acceleration technique for the rapid assessment of cardiac function, which achieves up to 12-fold acceleration. If you compare that to conventional imaging, which is up to 2-fold acceleration, it's a massive jump forward in speed. And this can be done in free breathing or in breath hold, depending on what your patient can tolerate. And the real paradigm shift is we can go from the conventional acquisition, which took 10 beats per slice, to all the way up to 1 beat per slice. And that's what we're calling real-time imaging, snapshot imaging, imaging in a single heartbeat to get that functional cine exam. You have the flexibility to dial that acceleration factor up and down. So in the middle, you see Sonic DL with 6x acceleration, which takes 3 beats per slice. Again, much faster than the conventional, and gives you flexibility depending on what you're trying to optimize for. Yeah, 1 beat cine, where now finally the acquisition speed is matched to the physiology. A little bit about how it works before I turn it over to Dr. Atkins to show us some real cases. So this starts at its heart from highly accelerated K-space, as you see on the upper left, where each phase has variable density sampling, slightly denser at the center, and then with the staggered KT pattern the net acceleration factor, as I said, up to 12. And we still preserve the best elements of what we know about MR physics. We use a physics-based unrolled model in a deep learning architecture. We use coil sensitivity maps. We use data consistency to preserve what we know about the true data and prevent things from hallucinating or going off the rails. And use a convolutional neural network in there which does the unaliasing and really optimizes for image quality and a very fast compute time. So all of this reconstruction happens in line at the scanner in just a few seconds. And it reconstructs high SNR, high fidelity images that outperform compressed sensing or parallel imaging. And here's a comparison of what it can do if in a patient who can breath hold. On the conventional technique, this would take 10 seconds, as we said. With sonic DL, 3 beats in a short breath hold with really high quality. What if the patient can't hold their breath? Typically, we would just do a multi-average approach conventionally, which takes even longer, and the image quality is still really not good at all. So 40 beats in a conventional multi-averaged approach. With sonic DL and a respiratory triggering algorithm, now this is 1 beat per slice, just incredibly fast and better image quality. So having our cake and eating it too. So for your overall protocols, conventionally parallel imaging would be used. Scan duration to acquire all your functional cines would be around 10 minutes. With sonic DL, 3 beats per slice, we're down to 3 minutes, and at 1 beat per slice would be even less. So much faster scan time. Images are even better than they were before and more comfortable for the patient. And really the take-home message for sonic DL is that this allows us now to tailor the protocol to the patient. So if the patient can tolerate a short breath hold, perhaps 3 beats per slice is what would be chosen. If they can't breath hold, we would run this as fast as possible, 1 beat per slice. If they're arrhythmic, also 1 beat per slice. What if we do want a really high resolution acquisition, for example, in a valve plane? We can back this off to high spatial resolution, high temporal resolution with 6 beats per slice. So you really have that latitude to tailor to the patient. This was developed in collaboration with Stanford and other partners. There's a number of publications listed here showing strong clinical evidence for accurate volume and function quantification in adult and pediatric patients, which we'd be happy to share with you. And last, just a few testimonials from some of our early partners. Matthias Friedrich calling it a game changer. Dr. Frandix Chan says, we want everything fast, but we want everything right. Sonic DL allows us to do that. And Dr. Pontoni says acceleration of sonic DL is so high, you can scan regardless of the situation and the patient. So with that introduction, I'd like to have turn over to Dr. Melany Atkins, who will show you the real thing in real practice. Dr. Atkins is Division Chief of Cardiovascular Imaging at Inova Health System and Medical Director of Fairfax MRI Center. So I'm really pleased to bring her to the stage. She's been a fantastic partner in the early stages of this technique, and I hope you enjoy the first clinical images of sonic DL. Thank you.
Thank you, Anja, for the introduction. Okay, so today for the rest of the talk, we're going to review the clinical journey that we've taken to integrate deep learning image reconstruction into cardiac MR. I'm very excited to be here today to show you that we've really made it all the way to the end. And why do we need Air Recon DL and Sonic DL? How can we use it? We're going to discuss Air Recon DL prior to Cine and with the new Cine or Sonic DL use cases with arrhythmia, claustrophobia, congenital heart disease, and increased patient throughput. So I think everyone in the room, we're all cardiac imagers, and we consider cardiac MR a labor of love. However, I don't think our patients really find our passion quite the way that we do. And sometimes I don't think our technologists do either. And so we really need to focus on more free breathing sequences and faster acquisition methods, but maintaining that same image quality. I remember when I was a resident, we would always be excited when we were offered to be the test patient for the day, or the volunteer in the MR scanner, and everybody wanted to be the neuro test patient or the MSK test patient. Nobody wanted to do the cardiac MR exam because it was more like a pulmonary rehab instead of like a nice, warm, loud nap. So we've got to get away from those long breath holds and get back to being more like our friends in neuroradiology, where you can come in and get your exam and be still and compliant and quick and be done. It's also labor intensive for the technologists. We really need to focus on more automated acquisition methods, and certainly for us in our area in the post-COVID era, it's been very difficult to find highly trained cardiac MRI techs. And especially in rural areas, if you think about rural areas where they don't have the cardiac MR volume that we do at some of our bigger centers, your MR technologist is really going to have to be able to scan everything. So we've got to assist those technologists and allow them better tools to be able to scan. And then it's labor intensive for the cardiac imager, so certainly we're also integrating deep learning models to assist us in post-processing as well. So deep learning image reconstruction. So this is, as Anja said, this has been a journey over the last number of years, and started with FSE-based sequences in 2019, and certainly afforded us excellent time savings, improved SNR in all of our body and neuro and MSK applications. But the really exciting part for me was the non-cine cardiac applications coming closely in 2020, and we really saw that this could make a huge difference in all of cardiac imaging. And my goal at that time was to acquire a full free-breathing cardiac exam. And we really need that for faster scan times. In our area, we have about a 3-week backlog for a cardiac MR exam. And if you have a device, we're looking at a 3 to 4 month backlog. And I know certainly there's other places in the US where that backlog is longer. In addition, we're scanning patients. These long scan times often lead to motion artifact and poor compliance. And you think about some of the most important sequences we're doing are at the end of the exam when the patient is exhausted and can't hold their breath any longer. And then we want to be able to scan all patients. Certainly an indication for a cardiac MR is arrhythmias. And so we want to be able to scan these patients with new onset atrial fibrillation and new onset ventricular arrhythmias. And we struggle with that due to the artifacts. So, and claustrophobia, I know we don't talk about it that often, but it is a real thing. According to the NIH, about 13% of Americans actually have claustrophobia, and I think if you sit in our MR center, we run into this problem every day. Now, we can get the patients through it, but when you ask them to hold their breath for long periods of time, it makes that claustrophobia worse. So we need something that's free breathing, and then the new coil technology has also really helped, as Anja mentioned. With air coils, it's more like a warm blanket as opposed to a hard coil that makes patients' claustrophobia worse. Slow heart rates, don't really think about that as a problem, but it takes longer, right? So we've got to be able to image those patients faster. And then we know we have good literature to tell us that exposure to sedation in our congenital heart disease patients and some of our younger children is cumulative. So we really want to avoid as much sedation as we possibly can, and that's also a cumulative time. So the faster we can scan these patients and get them scanned without sedation, the better. So Air Recon DL with non-cine sequences, the rapid single beat acquisition affords us to have whole ventricular coverage in 1 to 2 beats. With that deep learning, it increases the SNR by removal of noise. And we started with really integrating all of the available sequences into our protocols. Currently, we use single-shot phase-sensitive MDE for all 3. We acquire short axis, a horizontal long axis, and a vertical long axis stack. As part of our delayed enhancement, they're all done in 1 to 2 breath holds, depending on the heart rate. We've also added a short axis gray blood sequence, which I really like for identifying subtle subendocardial delayed enhancement. All of these sequences can be respiratory triggered. So if you have a patient that really cannot hold their breath, I recommend utilizing respiratory triggering. And then we often forget about some of our other sequences, but we have integrated single shot into all of those, all of our double IRs. And when you think about double IR imaging, traditionally it tends to be a long acquisition sequence. And so integrating single shot into that has been fantastic, and as well as T2 imaging. So this is an example of a patient, 76-year-old male patient with chest pain and shortness of breath. All of the images that you see here were utilizing air recon DL. So on the top left, we have our double IRs where you can see the pericardial thickening, certainly along the RV free wall, the best here. On the top right, we have our T2 imaging where you can identify some intermediate signal, and then along the bottom, we have our all three planes of single-shot phase-sensitive MDE, where we can see circumferential pericardial enhancement in this gentleman who has chronic pericarditis. So I think when you're starting to use new techniques, you really need to validate the findings. I think there was a lot of concern early on when we were using single-shot PSIR. Are we going to introduce artifacts? Are we going to be able to, is the delayed enhancement image quality going to be acceptable? And so this is just, I think, a nice example of a patient with apical HCM. On the left, we have our segmented PSIRs. We did acquire all three planes in this case. I'm only showing you the HLA and the VLA, and then the corresponding single-shot PSIR. So this is a 56-year-old female who was sent due to an abnormal echo. The segmented PSIRs on the left are, we acquired 2 slices per breath hold, and they were 16-second breath holds. So we have 7 16-second breath holds that were done for the short axis, the long axis, and then the VLA. So that's quite a number of breath holds during this exam. Interestingly enough, this segmented PSIR was done at a separate time as the single shot. The patient actually came back for a second injection. Otherwise, I don't think there's any way I could have convinced this patient to do all of those breath holds after all of the other SSFP imaging that we had done. On the right, we have the single-shot PSIRs. These were acquired as 2 14-second breath holds per acquisition. So 6 breath holds total for the single shot versus 21 breath holds on the left. So quite a big difference in scan time. And I think here you can appreciate that the findings and the image quality, I think, is very comparable. And you can see this smudgy apical delayed enhancement on both the sets of images. So I think we've all seen in our practice these SSFPs that we have on the left. You have an older patient, 84 years old, who comes in with new onset cardiomyopathy and ventricular tachycardia. And we tried a number of things to get adequate cine imaging. And as you can see on the left, we failed. The top is standard SSFPs and the bottom real-time imaging. But the beauty is we have beautiful 3-plane single-shot PSIR images, and we were able to use air recon DL and acquire these very quickly, so that motion artifact was not an issue. And this patient, as you can see here, has an inferolateral wall infarct with transmural delayed enhancement. So at this time when we integrated air recon DL, it was a huge win because we know we can do excellent, fast delayed enhancement imaging and double IR imaging on every patient, but we were still struggling for the cine component, so we really needed that. And this is another example of another patient we struggled to try to find excellent cine imaging, an 88-year-old female with atrial fibrillation. And she also had shortness of breath and really was unable to do any breath holding. So as you can see on the left, we've done real-time imaging. I think it's really hard to appreciate her tricuspid regurgitation here. In the middle, we decreased our resolution and made this a 6-second breath hold as a low-resolution exam. We increased the arrhythmia rejection to 50%. And so maybe it's a little bit better, but still a pretty subpar cine imaging in my opinion. But really good quality delayed enhancement on the right. So this is why we need sonic DL. So cine imaging is really our mainstay of cardiac imaging. And so we needed a faster, high quality cine imaging solution to solve those problems, those exact problems of arrhythmia, of claustrophobia, of patients who can't breath hold. And so, as Anja very eloquently described, it's integrating deep learning image reconstruction as well as parallel imaging, and we're able to choose our degree of acceleration and the number of R-to-R intervals that we're acquiring the images, and it really depends on each use case. And it's very easy to change those on the fly from your protocol from the scanner. And all of these images that you're seeing today were acquired on our 1.5 Tesla Artist. And to maintain temporal resolution below 45 milliseconds and a 1.8 millimeter voxel size, I recommend utilizing 3R to R as really the mainstay in the practice, and then titrate up and down depending on the use case. And so sonic DL can be it can be utilized as a rapid real-time free breathing as well. And so we know that in our patients with respiratory triggering, when we use the 1R to R, we can really acquire 14 slices in under 2 minutes with respiratory triggering. And so you can really do all of your cine imaging in this manner. It is retrospective gated, again, utilizing deep learning image reconstruction and parallel imaging techniques to marry those together. So this is actually at SCMR. This was our abstract that we presented this year in January. And we looked at 63 patients were evaluated of all ages, looking at mean and standard deviation between SSFP and DL cine function. At that time, it wasn't called sonic DL because it was before we had the product version. We demonstrated really negligible difference in our function calculation, and then we also evaluated on a 5-point Likert scale our image quality, and we felt that the DL cine at 3R to R actually had better image quality than the standard SSFP. Part of that is the temporal resolution of our 3R to R is a little bit faster than our standard SSFP protocol, and our spatial resolution is also better. And so when you look at the average acquisition time from a standard SSFP, you're talking about 2.5 minutes or so of tapping time, which at best is about 6 minutes of total acquisition time when you include stopping for patients to take a break and a breath in between breath holds, versus the 3R to R acquisition average of 3 breath holds, 16 seconds, and so less than a minute of tapping time or gradient time, and about 1.5 minutes total. So these are example images from that abstract that were presented. On the left are the standard SSFP, and the right, the 3R to R DL cine. I think both of them have excellent image quality, but when you're talking about less than half the time, certainly you're going to pick the images on the right. So the first case is a 76-year-old male patient with shortness of breath who was sent for evaluation of cardiomyopathies, had a high PVC burden, and a suboptimal abnormal echocardiogram, and so he was sent for evaluation of a cardiac MR. So on the left, we have our standard SSFPs with a scan time of total, we say 1 minute and 40 seconds, but obviously certainly even longer if you're talking about total scan time. In the middle, we have the 3R to R, and I think this is a good example when you have patients with really severe arrhythmias. The 3R to R is still a segmented technique. So in patients where you have that high PVC burden or severe ventricular arrhythmias, you have to really move over to a more effectively real-time technique in the 1R to R. And as you can see, the time savings here, the 3R to R still was a 40-second acquisition and 21 seconds for the 1R to R. But certainly you're going to get adequate function calculation from the 1R to R in this case as opposed to the others. So in patients with severe arrhythmia, really the 1R to R technique is the recommended, and it is important to keep in mind that if you want to keep your voxel size at 1.8 millimeters, the temporal resolution of the 1R to R is between 50 and 55 milliseconds. So depending on your use case and what you're looking for, you can back off on your spatial resolution a little bit and keep that temporal resolution at 45 milliseconds. But still approximate scan time if you do a breath hold of 20 seconds. And this can be respiratory triggered, and I'll show you an example of that. And it's about, for the entire stack, it's usually around a 1 to 2 minute acquisition. It uses 12x acceleration, and so you have to be a little bit cognizant. Looking for dark flow artifacts are a possibility. And so far in our practice, we've had sonic DL now for about a month, and we've calculated SSFPs, 3R to Rs, and 1R to Rs, and the calculated function has really been within inter-user variability for all three. In patients where the SSFP and the 3R to R are able to be calculated. For claustrophobic and arrhythmic patients, again, this is another 76-year-old patient with shortness of breath, left ventricular hypertrophy and aortic stenosis on echo, and was sent for cardiac MR for that evaluation. So here's the short axis images. Again, SSFPs are marred by pretty severe arrhythmia. The 3R/R images, I think, in this patient actually are much improved from the last patient, but again, the 1R/R I think is really the best image quality because of the arrhythmia. But more importantly, when you look at the three-chamber view and comparing the SSFP to the 3R/R, I think you can appreciate that on the SSFP, it would be difficult to identify the aortic stenosis. It would be difficult to identify the mitral regurgitation. The LVOT susceptibility artifact there, I think, would be very difficult to see. The aortic insufficiency. So all of those dephasing artifacts on the SSFP, because of the motion and the poor image quality, I think are a challenge and would be very difficult to identify. Versus our 3R/R, we can identify all of those and really get a nice evaluation of all those valves. Congenital heart disease is a big part of our practice, and I think that sonic DL is just a huge game changer in these patients. These patients are all complicated. This is an example of a 17-year-old male patient with hypoplastic left heart syndrome, status post standard bidirectional Glenn and fenestrated Fontan. This is a routine follow-up exam. In the setting of congenital heart disease, each patient is a little bit different when you think about them. Yes, we have the standard tetralogies and the standard hypoplasts and the standard TGAs, but they're all a little bit different. And so you have to really think about that and often need these different imaging planes. And so if you're spending long breath hold times to acquire each one, then your time, scan time is just up and up and up. And so the beauty of sonic DL is we can start with a straight axial, look at some of these findings, and then decide other SSFP imaging planes to look at the area that we want. And because it's so fast now, we can be very nimble and evaluate a number of different imaging planes. In this example, I do think that the SSFPs and the 3R/Rs on the left are still pretty good image quality, looking at the function of the systemic right ventricle. And on the right, we've done an oblique two-chamber type of view to look at the Fontan fenestration, which you can nicely see here, as well as the systemic ventricle regurgitation, which I think you can also appreciate as well. In addition, with patients with complex congenital heart disease, they're often associated with developmental delays and other syndromes, and so we really need to be able to be fast and free breathing. A lot of them cannot hold their breath for long periods of time, so we really need this rapid acquisition. This is the 3R/R in an axial oblique plane, again looking at that Fontan fenestration and the systemic tricuspid valve regurgitation here, and just the corresponding 4D flow image also showing the fenestration and that eccentric regurgitant jet as well. The next case is a 18-year-old patient with history of tetralogy, status post-repair. This patient is also 2 years post-pulmonic valve replacement and unfortunately had a poor quality echo. This is just our routine every couple year follow-up. And so on the left, you can see the 3R/R versus on the bottom, the standard SSFP images looking at the patient's right ventricular function. You can see part of the incoming bioprosthetic pulmonic valve as well. On the top right, we have our HLA images looking at the function of the right ventricle with really high resolution. And the beauty of this on the bottom, our 3D heart image, I think if you spend less time acquiring all of these cine images, then you can really spend a little more time identifying really high quality 3D imaging. This is an excellent look at the LAD extending posterior to that pulmonic valve replacement. And here's the corresponding 4D flow, looking at that pulmonic valve replacement with only a little trace pulmonic insufficiency. And I think on the right, this is a nice example just to show the associated metallic artifact that we have here. Even though there is some metallic artifact from that pulmonic valve, we can really see the function and evaluate that on this 3R to R exam. So we often don't consider slow heart rate a problem, and certainly those of us who do a lot of coronary CTA, we tend to kind of like slow heart rates. But when you think about it on the other side, in the world of MR, it really can be a big issue, because it's going to certainly extend your acquisition time. And so if you think about extending that, it's going to lead to poor image quality, of course. So a standard SSFP loc is 6 seconds, and with a heart rate of 4, it would be 12. That's just your standard loc. With sonic DR, in our practice, we're running the sonic 1R to R for all of our localizer images now, and those are 1 second, but with a heart rate of 40, it's 2. So this patient had an average heart rate of 42, and so on the left, on the bottom left, that standard SSFP stack took 4 minutes of tapping time. So you think about, that's just the gradient time, not including all of the stops in the middle. And also, I think there's some image blurring there, and I suspect that's because of so many heartbeat segmentations put together. Whereas the image in the middle is the 3R to R, which took 1 minute of tapping time, and in comparison to the image on the right, which is the 1R to R with 40 seconds of tapping time. So I think that the 3R to R and the 1R to R really have excellent image quality here. And certainly in a patient with such a slow heart rate, we definitely need these more rapid imaging acquisition. So respiratory triggering is a great option for the 1R to R acquisition. You can entire the entire HLA sequence in this patient was 1 minute 20 seconds with an average respiratory rate of 14 to 16. In this case, this patient was completely unable to hold their breath and claustrophobic, so we also respiratory triggered their single shot phase sensitive MDE. I just wanted to briefly mention the utility of the 6R to R. This allows for very rapid temporal resolution with very high spatial resolution, and really excellent for looking at valve pathology. And I think it will be great for mobile masses. We haven't had a case of a fibroelastoma in the last 3 weeks, but I'm hoping one is going to come here in the near future. But I think it's really going to be great for these small mobile items that sometimes we struggle chasing. Because either our temporal resolution isn't fast enough or our spatial resolution isn't good enough. So here with the 6R to R, you can really marry both of those. I do want to mention the 6R to R is a little bit longer of an acquisition, so I like this as a comparison. This is a patient with aortic insufficiency, a 56-year-old claustrophobic patient, and so we opted for the 3R to R here to evaluate her aortic valve for her SSFPs as opposed to the 6R to R, just for that faster acquisition. And I think you can still see here on the right, you can see there's incomplete coaptation, and she has that central regurgitant jet. So I think the image quality is adequate. But if you were trying to chase something small or a mobile mass, I really recommend the 6R to R as the way to go. And then I've just placed here on the top left, we have the 3R to R 3-chamber view, so you can see that nice central regurgitant jet and the corresponding 4D flow images. So in our practice, we've changed all localizers to sonic DL, 1R to R. We have changed our standard SSFP protocol, or we will starting next week, to sonic DL 3R to R, and with an expected time savings of 50 to 75%. We have optional in our protocol for 1R to R for any arrhythmic, claustrophobic, or patients who can't hold their breath with plus or minus respiratory triggering. And then we've already integrated Air Recon DL into all of our sequences, including 3 planes of single-shot PSIRs. We've added a gray blood short-axis stack. We use single-shot for our double IRs and T2s, and all of our scan times should be much less than 30 minutes, even in these patients where we've added additional SSFPs for more complicated use cases. So integration of deep learning image reconstruction is a game changer in cardiac imaging. Marrying Air Recon DL and Sonic DL, we've had significant time savings, we've had improved image quality, and certainly it's been one of the most exciting journeys that we've completed in my career. It's excellent for arrhythmic patients, claustrophobic patients, increasing patient throughput, and definitely a game changer. So thank you for your time and attention. I know everybody thinks that their cardiac techs are the best, but mine really are the best. So this is our group at Fairfax Radiology, and special thanks, of course, to Mike Vinsky from GE, who gives us a ton of support and help. Thank you very much.
Thank you so much, Dr. Atkins. I think we do have some time for questions, so if anyone has questions they'd like to ask, make your way to the microphone and we'll be happy to entertain some questions. I just did want to add some concluding thoughts. She showed some really fantastic clinical cases. We have the opportunity to give you the chance to look at them on your own. If you come by our booth, you can pick up a QR code, and that will have a link to a website where you can look at these images yourselves. It's a DICOM viewer, and you can see the cine movies playing. So that's a new feature we've added, so stop by the booth. But what I think is really impressive is the last take-home point that you made, which is, deep learning allows us to go faster and with better image quality. And that's the really winning combination that we've been looking for with cardiac MR for years, and now I feel like we're finally there. She mentioned that her site is the first to get Sonic DL, and it's now being released across the rest of our GE customer base. If you want to find out further details, we can also talk to you about that at our booth. So is there a question? Yes?
I have a question. Is it available on your platform Pioneer 3T as well too, or is it only 1.5?
All platforms.
You need a hardware upgrade too, or no?
Depending on where you are, most platforms can be done with a software upgrade, and so Pioneer would be a software upgrade. We can talk to you about specifics, configurations at the booth. Other questions?
For a great talk. I'm just wondering, since the deep learning is used at the data acquisition level, can this be applied to real time instead of just an acquisition?
You were cutting in and out a little bit. Are you asking if it can be applied in real time?
Yeah, it's like the same Sonic DL instead of just sending acquisition without EKGA real time.
Oh, I see what you mean. Yes. Right now, it is. By default, it is retrospectively triggered, so it assumes you have an R wave, and it is explicitly designed that way so that each slice is registered in time so that the functional analysis could be done easily with automated software. So that was a deliberate choice to make it triggered and gated to the R wave. We've had a lot of inquiries about a real-time ungated approach and looking at multiple heartbeats, which is something that we're working on in the research side, but it's not in the product today. Thank you for the question. Good question. Yes, sorry, I can't see you. There's a blinding light in my eye, so.
Good morning.
Good morning.
Question. I mean, I see than 10 million scans that you have integrated in the AI. Are you going to use this only for imaging, or are you going to use the neural networks to also do diagnostics? I mean, it will be incredible to use the neural networks to do diagnostic scans and get data from this large amount of patients.
I partially understood the question. Did you hear the question?
I think the mic it came in and out, but I think your question, so to clarify that, those more than 10 million exams are air recon DL across all body systems, so neuro, MSK. So that's been integration of air recon DL since the start. And so the training data for all of those was different. They do use clinical cases for training data, though. When they acquire, in fact, at our site, we upload we upload clinical cases to a database that will go on to be used for training data for real patients, or that will come in newer versions of Sonic DL. For instance, we're working on more things related to Sonic DL and Air Recon DL as we speak, and a lot of that training data comes from clinical cases.
Yeah, I mean, you can use these neural networks to make diagnostic studies, like, for example, looking at LG quantitated and get it out real quickly so that we don't have to analyze it.
You're talking about for post-processing as well.
Yeah, post-processing and getting, with all the deep learning that you have, use the neural networks to analyze it and give out the data.
Yeah, sure. I think at this point, a lot of the major software vendors are using AI to, certainly the one that we use utilizes AI in this way and used clinical cases as well for training for those also. Yeah.
Is there another question?
So I also share my sentiment that I love the text that we have. However, often we struggle with the quality of maybe planes that we get from our cardiac imaging studies, where they sometimes are not acquired properly. Training set, I assume that the training set is for each specific cardiac plane. Is that right? And so what is the effect if you have substandard cardiac planes being acquired? Does that affect how effective this method is?
That's a fantastic question. So it is robust to no matter what type of image you throw into it. We even have tested it, for example, in the kidney to make sure that it doesn't create a heart or something. And it works beautifully no matter where you apply it. So even to your question, if you have a slightly different obliquity of your plane, it performs very well no matter which axis you're in. And it has been designed that way and then also tested to make sure that it plays out robustly regardless of scan plane.
Which I think is really important, especially in congenital heart. I mean, certainly if your techs get the wrong imaging plane, mine do occasionally too, but especially in congenital heart disease where things are oriented in all sorts of different ways and you may need to look at a structure that's in a very odd obliquity. But so yes, yeah.
And part of what gives it robustness is that it's not we're controlling a lot of the reconstruction by using elements of things we already know. I spoke about that. We use properties of MR physics. We're not throwing everything into a black box, so there's a lot of control that we build into the reconstruction, so we feel very confident about it. Any final questions? Well, please, I welcome you to come by our booth or talk to Dr. Atkins or myself afterwards, and thanks so much for being here this morning. Have a great day.
Thank you.
In MR, long scan times mean imaging is compromised by the body's movement. What if deep learning could help MR finally keep up with the human anatomy? This is our vision for life speed imaging.